Hello, my name's Danielle. I'm one of the F1 doctors at Sandwell City, and today I'm going to speak to you about benign dermatology. Um, so, the learning objectives for today, we are going to cover how to take an accurate dermatology history. Um, we're going to talk a bit about describing the typical clinical features of acne and how to manage that. We are also going to discuss clinical features and management of different common skin infections, including bacterial, viral, and fungal infections. And I'm also going to touch on benign and pre-malignant skin conditions and their management. I understand some of my colleagues will be covering eczema and psoriasis, and also speaking a bit about malignant skin conditions. So I'll just go through this briefly. I don't know whether anybody else is covering it, but it is one of your learning objectives. I'm sure a lot of you sort of know how to do this already, but it's just to touch on the important aspects of a history in dermatology. So obviously identifying its onset and whether or not it was acute or gradual. Um, Especially in dermatology, it's important to know whether this onset was related to anything. Was there any sort of uh, anything that kicked it off, any illnesses, any changes to circumstances, any medications, anything like that, whether or not it's changed over a period of time, whether it's intermittent or continuous. Often the location and distribution of a rash is very important in dermatology. Different conditions act, centripedally or go from the limbs in. Uh, as well, in every dermatology history, important to talk about sun exposure and determining their sort of Fitzpatrick scale. And also social history is fairly important within dermatology because you can often find patterns of whether or not the skin condition is related to sort of, whether they're traveling, anything at work, anything at home, which may give indications as to whether there's any environmental factors contributing to it. Very important in dermatology to do a bit of a systematic inquiry because often dermatology conditions can be related to various systemic diseases. So the first thing I'm going to touch on is acne. Most people, when they think of acne, think of acne vulgaris, which is the more common of the two. So it can be split up into mild, moderate, and severe, which I've touched on here. So acne vulgaris usually happens in sort of ages about sort of 12 to 24. Um, there's sort of, I guess, two general types: non-inflammatory, which are the comedones. So when you talk about blackheads and whiteheads, so either open or closed comedones. And also you can get inflammatory acne vulgaris, which presents with it can present with anything from sort of macules, papules, pustules. You can have nodules and cysts with that as well. So the way that this is classified is based on sort of the number of comedones that you get and the number of how inflamed they are, and also where they're located. So the severe acne being those that involve cysts, nodules, usually some scarring, and also tend to affect the back and chest as well as the face. Acne rosacea, which is the sort of less common of the two, which I won't go into quite as much, but this is just important to remember, usually involves flushing, telangiectasia, and papules and pustules on the face. The way to differentiate is that there's no comedones usually with this, and it's often in older patients. You can get associated rhinophyma. Um, so you have probably sort of seen pictures of that where you get sort of swelling and growth in the nose. And the treatment for acne rosacea is metronidazole, plus similar treatment to some of the acne vulgaris stuff, which I'll go on to now. So the management for acne vulgaris is stepwise and are usually again based on how bad the acne is. So you kind of work your way up, of course, with mild, moderate, and severe. Typically, you start with topical treatments. The topical treatments could be anything from antibiotics, benzoyl peroxide, and retinoids. And usually, most use sort of a combination of these. So, with the antibiotics, they're usually very good, but if you use them on their own, you can get resistance quite easily. So, typically, they're combined with the benzoyl peroxide. The main problem with that being that you can get sort of irritation and bleaching sometimes of the skin. Uh, Similarly, topical retinoids again can be combined with this, but this can cause sort of photosensitivity and irritation. With patients, usually sort of who are going through puberty as well, and there's a lot of hormonal acne, oral contraceptives, so the combined pill, can help often with this hormone control. The next step would be thinking about sort of oral antibiotics. So different types of tetracyclines usually are used, typically for sort of longer courses, for about sort of 3 month courses, and then people are assessed at that stage. This is all usually at a primary care level. If it gets to a point where either someone has got severe acne or it's sort of treatment resistant, uh, they can then get that stage usually referred to a dermatologist, who only within secondary care can you begin oral retinoids, so like isotretinoin, because this requires blood monitoring of your liver, and is also associated with a number of sort of quite severe side effects. So it's important to counsel people before you start this, and also provide somewhere where you can assess those side effects. Sorry. So the next thing I'm going to speak about is bacterial infections. I've sort of grossly broken them down into the two main categories of bacterial infections, just because I found it a bit easier to think about it that way. Uh, so the two main bacterial infections that affect the skin are caused by Staph aureus and strep pyogenes, which you've probably heard bandied around a lot. They're quite common bacteria. They crop up in a lot of different systems, but especially in the skin, they cause lots of different things. So Staph aureus is usually responsible for uh, skin condition, but it says below skin conditions, so sorry, that's meant to say skin conditions, and tends to occur above the waist, so conditions that you have above the waist, such as boils in your hair follicles, carbuncles, folliculitis, impetigo, cellulitis, um, scalded skin syndrome, and eczema. So that is a way of sort of separating it like that. And with all these things, you can either treat them. So depending on obviously which it is that we're talking about, they can have local treatment or oral antibiotics, or obviously with things like cellulitis and when you get into scalded skin syndrome, sorry, the patients can become quite systemically unwell and may require IV antibiotics. With strep pyogenes, this is another gram-positive bacteria. It has a number of different subclasses, which you'll probably hear people speak about, sort of alpha and beta strep pyogenes. Um, it's a commensal bacteria in the throat, so it's often associated with things like pharyngitis, sort of tonsillitis sometimes as well. Uh, Along with obviously what I've already touched on with Staph aureus, it's usually responsible for impetigo and cellulitis. However, strep, it tends to be the sort of nastier things. So things like necrotizing fasciitis. Um, if you've got psoriasis with a superadded infections, often you can get sort of psoriasis, which you then get cellulitis on top of, for example. Um, Things like scarlet fever or strep toxic shock syndrome, um, or any sort of acute infection of the dermis which causes you to become systemically unwell, those typically are due to strep pyogeny. So it tends to be the sort of nastier infection of the two, and usually requires hospital admission with IV antibiotics. So I'm going to go on to talk a bit more about viral skin infections now. Um, the One of the more common ones is herpes simplex. So HSV1 mainly occurs extragenitally, whereas HSV2 tends to occur more on the genitals. Um, Both act in a fairly similar way. So you have a primary infection. With the type 1, you tend to get it as a child. So you can get this gingivostomatitis, which is accompanied by malaise, headache, fever. You get enlarged nodes. These vesicles can then turn into ulcers, and you can become quite unwell with it. Usually lasts about 2 weeks. Um, with the genital ones, you can obviously get these sort of multiple painful genital blisters, which then ulcerate. Uh, when you then get reinfected and you get these recurrent infections, typically you get them in the same place. So you talk about, people getting um, the cold sores on their lips tend to be in the same place and usually are set off by sort of stress, menstruation, underlying illness, that sort of thing. You tend to get sort of tingling, burning with it. This is the same with sort of genital, they present in a similar way, and tend to last about sort of 24, 48 hours, but take a while to go away. Um, they're fairly sort of simple, usually stable, but they can turn into you can get HSV, encephalitis, and meningitis, as well as disseminated herpes simplex. This tends to occur more in patients who are immunocompromised. So, if you see patients with stuff like that, it's important to do things like HIV testing, um, looking for any, reason why they're developing this. Uh, you can also get stuff like eczema herpeticum. So patients with really severe atopic eczema can get this sort of widespread HSV. You can also get HSV on the eyes, which it causes a keratitis, dendritic ulcers. You may also get a erythema multiforme, which happens because of it. So usually with these, you use a sort of topical fusidic acid, and you can also use either oral acyclovir in some cases, or acyclovir cream. Usually they only use oral acyclovir when you've got sort of widespread systemic involvement, or it's resistant to treatment and sort of atypical in any way. So that's an example of obviously what it looks like on the lips. The next one I'm going to talk about is herpes zoster. So most of you will have obviously probably had chickenpox and heard of it yourselves, and also know about shingles. So I won't go into too much detail with these, but what you're looking for in terms of your rash in dermatology, chickenpox usually is a development of centripetal papules. So you get sort of this slight malaise with it as well. These papules then turn into vesicles. The vesicles can then pustulate, and then they usually crust over and clear after a few days. Usually quite itchy. Um, there are some complications. Again, a lot of these tend to only happen in immunocompromised children or immunocompromised adults. You can get quite a severe illness in pregnancy. Also, it can be more severe if you get it in adulthood. So if you haven't had it as a child, but it's very rare. You can have scarring from it as well. Uh, the management, which will be sort of the classic question for you that comes up in these, MCQs. They usually ask you how long they have to be off school. They have to be off school for 5 days from the onset of rash. Usually, you don't need to use any antivirals, but if they are immunocompromised and they're at risk of having these complications, then it is important to use that. But you can give sort of babies and kids calamine lotion to help with the itching. Shingles is obviously sort of similar sort of thing to chickenpox. With this, you get a reactivation of the herpes zoster virus in a dermatomal region. So that's, typically people get it on the thorax in a sort of dermatome. They become quite unwell, malaise, get this sort of itchy, painful rash that comes up, lasts uh, anywhere from sort of a couple of days to a week. Can sometimes take longer to clear in more elderly patients. They become more unwell with it. They do often get vaccines as they're older patients. I've gone into a bit more detail just on this slide with herpes zoster ophthalmicus because it's quite an important one to look out for, more of a sort of medical emergency. With all of them, it's important to do a viral and bacterial swab. Uh, but basically the shingles herpes zoster ophthalmicus is when you get it affecting the ophthalmic nerve dermatome. So the danger with this is obviously if you see someone with the sort of shingles rash happening, and they get it on their nose, so the nasociliary nerve involvement, which is called Hutchinson's sign, the risk is that can then cause corneal ulcers and scarring, and can actually lead to visual loss. So that is actually really important to treat with antivirals. Uh, the management usually though is to just get some swabs, uh, especially with shingles. You may need to give sort of analgesia, stuff like gabapentin, amitriptyline for the post neuralgic pain. Um, that's what it looks like in little ones when they have that sort of. You can see some of these have already sort of crusted over. Others have already, yeah, some of these have already turned into sort of pustules as well. Some vesicles still present. And then that's an example of what I was talking about with the ophthalmic herpes zoster. So some other common skin infections, scabies. Usually the identifying thing with scabies is that it's a very, very itchy rash. Tends to occur first in sort of finger webbing, groin, armpit region, which is where it's most itchy. You get these burrows in there, and then there'll be a linear tracking pattern of these lesions from those sites. Important to consider, especially in children and patients from nursing homes or sort of institutionalized, anywhere that they can spread quite easily. It's quite easily managed. You treat with permethrin cream, which the patients put all over their body and then wash after 8 to 12 hours, and then repeat this after 7 days. It's important with this to treat all family members or housemates or anyone at the time, because it can spread very easily, and encourage people not to share towels and that sort of thing. I've also just mentioned here on this slide about candida infections. So I'm sure you'll learn about this elsewhere, but just as it was on your learning objective, I just wanted to mention it. This is usually, so it's a fungus, usually Candida albicans, commonly occurring. It'll come up in when you do gum and your genitourinary infections, because usually occurs in females genitally. Um, if you do get this sort of elsewhere, it's important to consider immunocompromised, because it isn't common to be having these sort of fungal infections in other locations, unless someone's on steroids and all this sort of thing. In which case, it might be a side effect of that. So another fungus is the dermatophyte infections. So you get tinea infections with dermatophyte fungi, the most common of which being tinea pedis, which is most commonly known as athlete's foot. Uh, it usually affects the sort of web space, and commonly associated with, the reason it's called athlete's foot is sort of sweaty feet, poor foot hygiene, putting on wet socks, all that sort of thing can cause it. You get this sort of soggy interdigital scaling, they call it, usually in the sort of fourth and fifth inch space, but you can get it anywhere really. You can get sort of scaling and dryness on the soles, and you can get these recurrent episodes of sort of maceration and desiccation, where you have this sort of wetness with the loss of the epidermis. You can also get it on the toenail. You can either get it on the toenail just on its own or associated with tinea pedis, and usually it's at the free edge of the nail, and the nail will change color. It can be sort of yellow, crumbly, maybe some sort of actual nail changes, some flaking at the side of it. The other common site for dermatophyte infections is your head, so tinea capitis is called. Typically covers quite a large area over the top of the scalp, and you get this sort of erythematous scaly plaque, with usually associated with hair loss and dryness. The hair loss is usually reversible once this is treated. This typically affects children. Again, can happen in immunocompromised though as well. With tinea pedis, you usually treat with local antifungal creams or nail lacquers if it's just the nail involvement. Usually, you only need to use oral if it is widespread or it's not responded to the sort of local treatment. With tinea capitis, you do tend to just go straight to the oral anyway, so that's griseofulvin, which the main side effect for this, actually, interestingly, is loss of taste. So people will often complain about when they're on this medication for quite a long time because they can't really taste anything. That's just some images of different types of nail involvement and what that can look like. Okay, so moving on to benign and pre-malignant skin lesions. So in this slide, I've just sort of tried to outline as best as possible a bit of a sort of summary of actinic keratoses and Bowen's disease. So actinic keratosis, also known as solar keratosis, usually occurs in sun-exposed areas. Um, Typically, there's more than one. They're usually multiple. They're these sort of pale, scaly patches or plaques that you get. Can often sort of become crusty around the outside. They can vary from anywhere from sort of pink to brown. You can sometimes have a whitey, yellowy sort of surface. Usually linked to sun exposure. Hence, the in these sun exposed areas on the head, on the cheeks, on the sort of chest and back and shoulders and all that sort of thing. Um, if you've got more than 10 of these, there is a slightly higher risk of this developing into SCC. It's still only about a 1% risk. Uh, I've just noted as well, so you can get this cutaneous horn with it as well. Um, with that, obviously, I think a lot of people would be a bit frightened and think, oh, I need to biopsy this sort of thing, because you can obviously get that from actinic keratosis, but you can also get it with SCC. Um, if there's sort of just individual ones, it's really easy to treat with cryotherapy. Otherwise, you usually use medication. Uh, Curettage and sort of photodynamic therapy are usually sort of the next stages, um, if once you've tried the first two steps there. So with just moving on to Bowen's disease, also known as intraepithelial carcinoma. With this, you tend to have this sort of asymmetric lesion with quite well defined borders, usually pink. Can have some areas of sort of thickening and scabbing. Again, this usually is more common in sun-exposed areas. About 3% of these develop into SCC. It's sort of considered like a pre-malignant thing, because obviously it can turn into SCC, although it's it's actually just confined to the epidermis. So you can look at lots of there's good images out there on sort of the internet that will show you kind of the progression of the different levels of the skin that are affected by these conditions, and how it does then obviously progress to SCC when it can affect deeper levels. It's often a lot slower growing than SCC. It usually only involves sort of the single, quite well demarcated lesion. A sort of, I guess, fun fact, it is highly linked to arsenic exposure. Sorry, I spelled that wrong on the slide there. But again, one of those things that's more common in immunosuppressed patients. So I've just noted there, again, going back to why it's important to take a full history. If the patient's got a history of something like rheumatoid arthritis on methotrexate, this is something that you can see with that sort of thing. In terms of treatment, uh, very similar to actinic keratoses, with using creams and medications in diffuse lesions. Um, Often they can just be left under observation, especially with frail elderly people. You can use cryotherapy for individual lesions, but if you do have any concerns about it being SCC, I mean, especially seeing this as sort of junior doctors, if you're seeing it in GP, that sort of thing, I think it's reasonable to refer to a dermatologist if you suspect that there's SCC there, so that they can sort of biopsy and excise it. So the next two slides are just quickly touching on the different types of nevi. So obviously one of my colleagues will be going into melanoma a bit with you, and how nevi can sort of develop into melanomas. But the benign the different types of benign nevi that you can see are sort of outlined here. So you've got your junctional nevi, which are sort of the most common. Most people will have these. It's just sort of a flat mole, really. Um, you have your dermal nevi. So this is obviously those nevus cells are now within the dermis, whereas with the junctional one, these are typically epidermal and dermal. A compound nevi, so these cells are at the epidermal-dermal junction as well as in the dermis. So it will have a raised area as well as this flat patch. Uh, Combined, so this is a image of sort of two different moles within the same lesion. So you have a compound mole and a blue nevi in there as well, so in the sort of middle bit there. You can get these thing called blue nevi, which is a dark blue colored mole. You can also get halo nevus, which is a mole surrounded by a pale ring, and you can then get dysplastic or atypical nevi, which are the ones that you would, good. It's good to keep an eye on these ones because they tend to be sort of irregular pigmentation, and they're the ones that are more likely to turn into a malignancy. So if you have any that you're worried about like this, good to just keep under observation. Most of these though don't require any management, purely reassurance. You would only excise these, like I said, if you suspect a malignancy, or if you've got someone that is in um, a location that's becoming sort of inflamed, traumatized. Um, Obviously, there's people who will want these removed for cosmetic reasons as well, but that's not really something generally under the NHS, I don't think. Um, these are just some sort of rarer but also benign lesions. I won't read sort of too much into this. You guys can use these slides for your own revision though. But this is just showing examples of dermatofibromas, neurofibromas, and epidermoid cysts. The neurofibromas are usually associated with sort of genetic neurofibromatoses. Um, Whereas the other two, dermatofibromas and epidermoid cysts, aren't always associated with stuff you can just get them. Epidermoid cysts usually have fun. If you like the pimple popper videos, you can get sort of epidermoid cysts with these sort of soft cheese-like contents, which with this sort of central punctum that you obviously can sort of squeeze out often. And this is just talking about pyogenic granulomas, seborrheic keratoses, and viral warts. So pyogenic granulomas usually somewhere where there's been a previous infection or trauma, usually quite quick growing, can happen in pregnancy apparently, and also on the oral contraceptives, more common in young people. Seborrheic keratoses, so these are essentially sort of warts. They're usually quite sort of stuck on, they're described as, and you get these well demarcated warty plaques, usually common in old people. They tend to have quite a lot of these, especially on their backs and all that sort of thing. Usually you just cryotherapy these. They're not too worrying. um, they can be associated, this is quite sort of rare, but obviously with the gastric adenocarcinoma. And then viral warts, these are usually caused by HPV. A verruca is a form of this, so you can get obviously verrucas on your feet usually, and warts sort of anywhere. Tends to be in school-age children or immunocompromised. That's just an image of the seborrheic keratoses that I was saying that's stuck on. So, to summarise, we've talked a bit about how to take dermatology history, we've touched on acne, skin infections, and benign and pre-malignant skin lesions. Hope that's been helpful. Thanks very much.